A qualified cookie. Let's start like
Jamaica, it's too early. It's too early.
No, I didn't know what he said. That's what I was like, but.
He's like, I'm ready.
Okay, so we don't have much further to go, guys.
Hey.
We're gonna wrap this
when it's-
section up. I keep almost
Yeah.
saying chapter. This section up with T-spine positioning. And what's nice about T-spine is your AP and lateral are essentially just collimated chest X-rays, as you guys should know from clinic, right? One small little fluctuation on that when we get to the laterals, and we'll talk about that when we get to the slide here in a minute. So let's move on. I'm going to go through this part kind of fast. This is all the same info we had in the C-spine intro, guys. We're going to talk about the guidelines. It should all look like review because it is. So of course, guys, your biggest enemy, once again, those artifacts. Now for this one, it's not going to be your earrings or your false teeth or your scrunchies. People still wear scrunchies? Or those out? I think that was
It was back in your
No,
time.
they came back.
Scrunchies are back?
They
Okay.
came back for like half a
Anyway,
year.
all that stuff in the head area, not a concern, but we're back in the neck and chest area. That being necklaces, like I said last time, those necklaces are your arch enemy because they are gonna be hidden and they're gonna say they removed the necklace even though it's still there. But what else? Just like a chest X-ray,
The bra.
the bra needs to come off. We need to make sure
Jewelry.
those lead stickers have been removed.
Piercings.
Watch out for those evil lead stickers. They haunt my dreams to this day because every time you ask, is there anything on your chest? They say nothing. Lo and behold, there are those magic lead stickers all over the chest. And you gotta repeat that X-ray, and they're gonna be screaming as they pull off the stickers because people have low pain tolerance with those stickers. They do kind of hurt though, especially if you're allergic to adhesive. Like, I think I told you, my wife's allergic to that adhesive. And when she removes the stickers, like somebody like pull her skin off. So be careful with those, especially if they say they have an allergy. Bless you. Make sure you provide a gown, of course. Don't put your patient up there naked. That would not be proper. Like some techs have been known to do. We'll talk about that. Yeah, true story. Really messed up in the head.
Same person?
I'm not going to say that. I think you fill the blanks, yes.
Good.
Secure patient possessions in a designated manner and location, of course. Make sure they're not losing their things. And your ambulatory patients, guys, for T-spine, as usual, guys, if they can stand up, that's going to be your easiest way of getting these X-rays. But you can do them lying down as well. I think in lab they'll do them laying down. Yeah. Me personally, I prefer doing them standing. I feel like it's easier. But you know, do what your lab teacher says.
Which one?
The T-spine. Me personally, if you stand them up, it's a lot easier than laying them down. I've always done my T-spine standing if the patient can't stand. Just like a chest X-ray. Just call me a chest X-ray. Keep it easy.
Would that just be like a protocol per location? Like if they know?
It's just preference,
Oh, okay.
comfort level. There's not really one that's considered better image quality wise, but I would say for ease on you and convenience, it's easier to stand them up. Personally. Yes.
Also, when you have them standing up, you can also see, isn't it better though, because that way the radiologist can see how the vertebrae is stacking up on each other with weight bearing?
It's not really going to be a big difference from
Oh, really?
standing versus lying down, but it's good point to think about. It's not really going to show a big difference on the vertebrae per se, but it's just more so, it's a personal choice, what you prefer. Of course, trauma patients, if they're on a backboard, they don't stand them up. That's not going to work out so well for you. Keep them lying down. Do that on the stretcher, and then of course do a cross table lateral, almost a C lateral T-spine. Get that lateral image because you're not going to be able to roll them around if they're in a trauma situation. All right, use your smallest IR that will demonstrate the anatomy for your T-spine. It's always going to be a 14 by 17, by the way. We're not going to use a 2 by 12 on T-spine unless you have a child, of course. A small child. But T-spine should always be done on 14 by 17, and we're going to collimate very harshly on that horizontal X-axis. Get my axes all messed up. The X-axis, you're going to collimate very harshly because what's the star of our show? Just the spine. We're not doing chest X-rays, which many of your techs that you work with do not understand that about T-spine. They just open it up and they just do basically just do a chest X-ray. It's supposed to be T-spine. Collimate that down because those lungs absorb a lot of that radiation and it really blurs out the T-spine if you have a lot of lungs on there. You want that T-spine to pop, just like come out at you like a 3D picture. You do that good tight collimation, it's really gonna make a big difference. And really for all your spine work, tight collimation is really key to make those vertebrae, those small details on those vertebrae really pop. All right, this is easy for this section. I'll get your question in a second. 40 inches for all T-spine X-rays, of which we're only going to talk about 3 positions, so that's pretty easy to remember. Don't mix it up with your C-spine, because there are variances of 72 and 40, depending on what we're looking at. But for T-spine, it's always gonna be 40 inches, period. Question, Emily?
So you know how they're saying whenever they do T-spine, they open it all the way up, and we're learning to tighten it up. So what do we do if we're comping and they just say, no, you don't get the comp because they're
Because you didn't open it?
well, yeah, like if it's not their way.
Then they're stupid.
Look.
Normally they come back and they just open it up.
That's just stupid if you ask me, but, I know you're at the mercy of what the tech
Yeah.
wants, so.
Depending on.
What I would do in your situation, if they're saying you need to open it up for your competency, do it their way, just make sure you inform us that they made you do it that way, because we know how they are, we do. But if you can collimate, it's gonna be a lot more optimized, trust me on that. All right, y'all know this slide's coming. Y'all got this twice on Monday, right? On those digital markers, because we always use digital annotation, right?
Always.
Woohoo!
Oh, you disappoint me. No, of course not. Now, in real life, yes, we're going to. Yes, we're going to. But should we?
No.
No. And when the registry asks you if you should, even if it's a fancy answer, do you say yes?
Maybe.
No, you do not say maybe. You say absolutely not. Capital N-O. You do not use digital markers. It's always a physical anatomical marker. Period. Go. All right, of course, close collimation, not only for optimizing our images, but also for protecting our patients, minimizing that exposure overall. Keep in mind, spinal x-rays are high radiation exams, so we're penetrating a very thick area of the body. Thus, our mask techniques are gonna be a lot higher, producing a lot more radiation to the patient, and scatter, by the way. We'll come back to that scatter in a second. So we get to that lateral T-spine, it's gonna cause us a little bit of a problem if we don't use a little device that we have in all our rooms to help mitigate that. Yes,
No.
really? You say
It's
really?
a,
Oh, grid. No, no,
it's
no,
the,
not a grid.
sheet,
No. But I like your thought process on that. That was good thinking.
sponge thing.
Grid would only come in play if you have a very large patient. You gotta clean up that scatter because it's just not showing up well.
It's the
but-
sponge, right? Or some kind
No,
of.
it's not
Sheet,
the sponge.
sheet.
We'll come back to that. We'll come back to that. Hold that thought. We'll come back to it.
Yeah, a shield.
We'll come back to that. Don't spoil it. Don't spoil it. Okay, patient instructions. We're of course gonna explain everything very thoroughly to our patients, make sure they know what's going on. If they know what's going on, they're gonna work with us more efficiently, so we can get it done quickly without having to do any of those nasty old repeats. Now, something to keep in mind, respiration. When it comes to the lateral T-spine, you have multiple respiration options that I'm gonna go over. If you can master breathing techniques, it's gonna be the superior breathing technique for lateral T to bore out the rib markings properly and just really make that lateral T pop. But breathing techniques can be very difficult. Have any of y'all seen breathing techniques?
Like co-starter?
Have y'all seen anyone do breathing techniques where
Only
they
on the chest.
manually set the KVP MA in seconds and they hold it for a long exposure while they breathe?
Mm-hmm.
Very difficult to do. I've only done a few in my life because I mean it looks beautiful if you master it, but it's hard to calculate and get it right. And in my experience, most people that try to do them end up having to repeat because they never get it right the first time. It kind of defeats the purpose because you're re-exposing the patient. So not required, but if you're a master at breathing techniques, it's going to give you the prettiest image overall. That's your optimized way of doing that exam. All right, so essential projections of the T-spine. We only got a few guys. We're gonna start with the AP T-spine. And of course, we can either lay them flat on their back or upright. By the way, these will only ever be AP positions. Why would I not do PA like a chest?
The spine's on the back.
Because think of where the anatomy is, you're correct. The spine is in the posterior aspect, and when we do x-rays, most of the time, except for some of those weird obliques, we want that anatomy as close to the IR as possible. With the spine, that's in our posterior region, thus it's always going to be AP, where we're putting the spine as close to the IR as possible, because that's the star of our show, as I always say. Shoulders should be in the same horizontal plane. In other words, you don't want one shoulder slumping down to the left, the other one raised. You're going to have your patient look like they have scoliosis if you do that. Let them stand out real straight, real tall, proud and tall, so they can get a good analysis of that spine and make sure everything's aligning properly. Arms should be by the side. Now it does say arms by side, but my personal preference, just like with a chest x-ray, guys, if you're doing like an abdomen x-ray, and you're doing an AP standing abdomen, I always tell them to do this, put the arms to the side. Why? Because some people have a lot of arm tissue, and sometimes that arm tissue can obscure what you want to see. So just to be safe, have them do this, get them up out of the way, and you don't have any risk of it being in the x-ray. It's not taken away from your image quality. That's optional though, that's just what I personally do. Now, this is a big one, guys. I want you to put a big star on this. I don't know if y'all talked about this in PRE. This concept right here has been on every person's registry to my memory, right here, this exact statement. And they always use the T-spine for talking about this concept. So it says, if possible, we're gonna orient the patient so that the lower thorax, the inferior region, is at the cathode end of the x-ray tube. So if the inferior aspect is at the cathode, the head and upper torso is at the anode. Why? Because that's such a thick region of analysis that if we position the tube in that way, it's just going to give us an overall better quality image. It's the way the physics work behind the tube. So write that down, guys. For T-spine x-rays, and they will ask you this, you will see this in registry review. Anode ends towards the head, cathode end is towards the lower region, towards the feet. And that's to maximize the image quality for our T-spine x-rays. Like put like 7 gold stars around that.
Anode to the head.
Anodes towards the head, cathode towards the feet. And if we do that, it's just going to really maximize that picture quality, image quality.
How does that affect the image quality?
It just enhances it a lot better.
Do you have a comparison?
I don't have a comparison, but I should look for one to show you. It does make a big difference, though. Yeah, I need to add that to the slideshow.
Mr. Fun did tell us about that.
Oh, good. Good. I figured that was a
The
PRE.
example he gave you was the foot, the toes.
Very good. All right, so part position, guys, MSP in the center, just like a chest x-ray. Now, if we're supine, lying down, this is very important. Put another big star by this because they love to ask this question. We naturally have a kyphotic curve of the spine. We're going to reduce that by flexing the hips and knees to place the thighs vertical. That'll make the back overall flatter because the way our back curves, when we're lying on the table, we're going to naturally have some OID occurring. That natural kyphotic curve, guys. If we position the legs, hips, and knees in this fashion, it's going to reduce the curve, putting that spine as flat as possible, as if we're lying down, supine. If we're upright, we're going to make sure that weight's equally distributed on both feet, shoulder width, just like a chest x-ray. Once again, don't have them tilted to one side, putting all their weight on the left side or the right side. They'll end up looking like they have scoliosis, and they might make a misdiagnosis there. Both feet firmly planted, shoulder width, when we're standing up. Now we do center to T7, but there's a little light trick once again that should look very familiar. It's just like a chest x-ray. If the IR is placed 1.5, and that's your light by the way, the IR and the light, 1.5 to 2 inches above the shoulders, that's going to center it to approximately T7 because we do this in AP. Now, I'll show you what I personally do. I'll tell you before I go to the next slide. We do center at T7, just like a chest x-ray. So what I do is I position them like a chest first. I have them turn towards the tube. Find my T7 and I turn them around to the AP position. That works for me. But you can also do that light trick, or you can do halfway between the jugular and xiphoid process if you want to use that method as well. Also the shoulder blades, the inferior angles of the scapulae. That's also a T7. Just like chest x-rays, guys. We're positioning just like a chest x-ray. AP chest to be exact.
So to flex the hips, that's whenever you
Flex the hips.
Yeah, and then you just push butt up.
Yes. Like you're doing like a what's that exercise?
Bridge.
Bridge, yes, like a bridge. Thank you.
But their feet aren't flat, right? They're just
Can you
doing
just
the
bend
motion.
your hips
Well,
and
you
knees? Just bend your knees.
Bend your knees, yeah.
Oh, okay.
Cause I was saying he's gonna be.
And then it's
Hard,
honestly,
like,
guys,
especially if you've got a back injury.
it's a very
to do that.
subtle, it's a very subtle movement, and a lot of people won't be able to do it because of back pain, of course. But if they can, get them to do that. It's just gonna give a better look overall. It's gonna reduce that curve. All right, guys. So like I said, CR, we're still at T7. The exact location in the AP is halfway between the jugular notch and xiphoid process. That can be hard to determine. Plus you don't want to be touching people's chests. Personally, once again, what I do is I turn on PA, find my T7 like I know how to do for a chest, and turn them back into AP. If they're on the table, of course, it's going to be more difficult, but if they're able to stand, which is also why I have them stand, I can be a lot more accurate, just like a chest x-ray. IR collimation, guys, your x-axis should be collimated to at least 7 inches. That's considered the ideal amount of collimation to make that T-spine pop. We're not doing 14 by 17 open. We're collimating in your face. You know what I'm talking about. We're collimating to a 7 by 17 at least, guys. And then respiration for the AP T-spine, we're suspending at the end of a full expiration. Expiration, not inspiration like a chest. Expiration. I put a big star on that because we're in the chest area and our natural inclination is to do an inspiration. But we do want to blow all the air out for this one. Expire. Expiration.
When you said inspired, I thought that commercial popped in my head when I think it's a car insurance and they're talking expired. That's what I just thought about when you said expired.
So did they get your business as a result of the commercial? Did they win over your business as a result of the
Yeah,
commercial?
they
Oh, you
did.
do some?
Yeah.
The commercial got you?
Expired.
So do I have some people in here where the Gecko got you too?
It was flow for
I
me.
like that.
It was close.
When I crash, they pay them.
I use USAA. If
But I'm not
if
with
you can
State
get in
Farm.
with USAA, that is the best.
Is USAA the one with the
For
Mayhem
military,
guy?
I thought.
No,
No,
USAA is like a military
That's in
Okay.
insurance. If you have like a military family member, they can get you on with USAA. You talk about save some money, and let me tell you, every insurance company is scared of USAA. They won't even fight. My wife rear-ended somebody a few weeks ago, and it cost us nothing because USAA basically won the battle, even though it was our fault. They don't even try to fight against USAA.
But
Like,
your insurance went up?
huh? No. Nope. It did not. It's only our fault too. It's her fault.
Be proud of that.
It's just
Throwing her under the bus. Yeah, she can't drive at all.
That was her fault.
He's proud of that.
You said, yeah, it wasn't me driving. That was her.
Yeah.
USAA.
It was totally her fault.
You have to have a military.
That
Yeah,
plug.
military.
So you could probably use it then. But it's worth it if you can get in with them, and their prices are so good too. I'm doing an advertisement for USAA. It's gonna be your bonus question.
God.
What insurance
What
do
insurance
you
do
have?
I
No. The question is, whose fault was the wreck?
Who hit that car? Who hit that car?
2 points.
The answers are gonna be like,
Let's do
Ariel,
one.
why,
Now Benjamin just crashes into my vehicle with his skates. I'm about to skin his hide. My boy, if you run into my car one more time with your skates or your bicycle, I'm gonna lose it.
I'm gonna take you to X-ray.
And he looks at him, he's like,
He got some roller skates for his birthday and a new bicycle, so he's been out every day on the drive. We have a really long driveway in front of our house, and he keeps crashing in my car. He doesn't crash in the van, he crashes into my car. The van's like a tank, you can take anything, but
Yeah.
my car is like,
It's softer. It's more pleasant.
softer, yeah.
That aluminum.
Okay, back on subject here. What are we looking for, guys, for an APT spine? Of course, we're looking at all those individual vertebral bodies, particularly T1 and T12. That's the star of our show. We also want to see the intervertebral disc spaces and the transverse processes. Now, that's a big one. It's why we also want to collimate tightly, as well as do that anode-cathode effect, and really get a good image. Because if we don't, they're gonna become.
Coffee?
Cookie. You need a cookie.
He doesn't need them anymore.
All right. They're going to become invisible. I still can't talk. They're going to become invisible if we don't do those exact criteria to make them pop. So we do want to see transverse processes. Thus, you should be collimating. You should be positioning the patient with the anode and cathode effect we talked about, and using a proper technique and getting that expiration effect on the respiration reconstructions.
Which was the start of the show?
Hmm?
What's the start of the show?
So 1 through 12, vertebral bodies, the disc spaces, and the transverse processes, which we can see on the sides. You'll see them? Transverse processes, which you have a left and a right.
Or they the little
vertebrae.
things that look like this?
Yeah, kind of like little fins on the side.
Okay.
Now, I used to actually have a bad stutter. I used to stutter a lot when I talk in front of people. Every once in a while that comes back out. So I have
You
to
can't
sit
tell
down
it.
and recharge.
You can't tell
reset.
at all. It's just that you point out and you still you can't tell.
I used to get so nervous. I'd be stuttering all over the place when I was talking in front of people.
I hate that I say,
Yep.
I've tried to purge all my
I was like, what did you say?
Sometimes you
She's
start
so
doing
like
speeches that
stuttering.
try to teach you. They still come out sometimes, but so what you do with is you learn to do what they call an intellectual pause. You'll see most of your politicians, they do that too. They call it intellectual pause. In fact, Barack Obama was the best at it. He would pause, get your thoughts, and start up again. They call it intellectual pause. They always use him as a model in speech class because he was a master at it. And when you feel an coming on, you don't let the come out, you pause. And people in the audience don't notice, they just think, well, he's just thinking really hard. He's just gathering his thoughts. But everyone's like,
You don't know what you're talking about.
yeah. Naturally, it's like a psychological thing. So they call it the intellectual pause. Yeah, if you ever want to really see how to do a good speech, like Barack Obama was really good at his speeches. Like he really hit those inflections really well, and he would do those pauses and his thoughts and just flow.
We're gonna see you do your pause in the T17, huh?
Dang, that was a good one. That was a good one. We just did it. We just did it.
He's so nervous. Look at him.
Hopefully I won't be pausing.
I wasn't sure if he like shut down or just like intellectual pause.
We'll make sure I don't look in y'all's direction when I'm talking.
Don't
We'll-
look at me.
We'll just be in the back like this. Oh, and we're good on Eileen.
On what?
Eileen.
Oh,
Yes.
thank you, sir.
You are.
Thank you. All right, guys. All 12 thoracic vertebrae once again. If you're clipping any of those vertebrae, either they're too high or too low. You're not at T7. You must have 1 through 12. We're not interested in C or L though. Only T 1 through 12. No rotation. How would you check that? We look at those spinous processes going down the middle. If they're going to either side, then we have curvature or rotation of the body. Vertebral column must also be aligned in the middle of the radiograph. That's important too. Make sure you're centered on the y-axis correctly, because if you're not, that quality is going to dip down severely. They're not centered that film. And of course, proper technique. That's always on every single X-ray. I'll have to repeat that. Now, personally, on this radiograph, I would have culminated even tighter than that. That's within range, but I would go tighter because the tighter you can afford to go, I mean, it's just really gonna make it pop in your face. It's gonna look beautiful. Yes.
I have a question. So, like in cases like this, when it comes to the collimation, you don't think about maybe scoliosis sometimes?
Well,
Like-
that's where you gotta be careful, and usually on the order, it'll indicate scoliosis.
Okay.
But you can usually tell if a patient has severe scoliosis. In that case, they're probably not even gonna do a T-spine anyway. They're gonna do a full scoliosis series,
Okay.
which we'll talk about that in the next section after this test of how we do that. Have y'all seen the scoliosis x-rays at all in clinic? They're pretty cool. They stitch them together. So obviously we don't have a cassette that can account for the entire spinal column of adults. So what they do is they have a program that's installed in certain x-ray machines where it will use one cassette, but it will take several exposures on that cassette at different intervals. So the two will go like this. It'll point up, beep, it'll point down, beep, and then point all the way down, beep. Then the computer will take those 3 exposures and stitch them together, which they call partitioning, and it'll make one full image once it stitches them together. It's really cool, really cool. That's how they do most of your scoliosis x-rays these days. They also have what's called, I'm getting ahead of myself, an EOS machine. Have y'all heard of the EOS machine? Very cool technology. In fact, to my knowledge, the only one in Houston, Texas, I think even the state of Texas, but, well, no, I think they have one in Dallas. The only one in Houston, Texas is at Texas Children's Hospital. It's called the EOS machine. It's a very advanced scoliosis machine. It does more than just scoliosis, but they use it for spine. And it's a hybrid of X-ray and CT technology. And what's really cool about it, I've shown you how some of these patients have extreme scoliosis where they can't even get out of their, they're like bound to a chair and they're all like folded over like this. Like you can't get a proper X-ray series on a patient like that. But the EOS, you can really put them in the machine. It looks like a big tall column. It's white, it's really pretty. It looks like a really futuristic
clear?
machine.
Is it the clear one? No?
You have a picture of it? Yeah, that's it right there.
Okay.
They
I don't know
can
if they're really-
literally go in the machine, in the chair,
Watching the video.
wheelchair, and that thing will take a perfect image of their entire spine. It spins around them, and it's lower dose than X-ray.
Oh, wow.
And it can do 3D reconstructions of the spine, too. It's really cool, really, really cool. So my theory is, because it can do more than just spine, my theory is that's probably the next evolution of X-ray. Because it can do anything. It's a hybrid of CT and X-ray, and it's extremely low dose. It's just extraordinarily expensive. That's why we only have one in the medical district right now. Yeah, so
So,
cool stuff to look forward to.
in the future, you think, like, we won't have to position it, we'll just.
So if they, with this
That was
technology,
literally my
don't,
essay.
let's just say, they just put them inside that device. It goes around them, and this gives you a perfect image.
We should take a field trip to it. Yeah.
We should.
Like,
I wish I could do that. I wish I could do that for y'all. It's really cool to see. I used to go over there and look at it all the time. Like, it's fascinating. I never got to actually use it because I didn't work day shift and only use it during the day shift. But I got to go see it and check it out a little bit.
Does it rotate too much that you get your hand on spinning?
Hmm?
Does it move to spin too much?
Well, you can't see it spinning. It's just it's inside of like a bunch of columns. Like the camera is
The patient doesn't.
No, the patient doesn't spin. Oh, that'd be like a carnival ride. No,
All right, time for the X-ray.
you know how CT spins, right? It's similar to how CT spins around the patient. Yeah.
Is this scary for like claustrophobic patients?
Huh?
Is it scary for claustrophobic patients?
Not really, because you saw the picture, right? It's open, like you can see. It's open like in
Oh,
that
okay.
picture.
So it doesn't like close in?
I got some stuff to show you on the next section on the L spine. I got a bunch of pictures of it to show y'all. So
That looked like it was like.
stay tuned for
somebody
that.
drew it.
All right, back on track. Lateral T-spine, guys. Once again, it can be done either upright or recumbent. Personally, once again, if I can stand them up for this, that's what I'm going to do. But we can do it lying down on a table. Now, we can do right or left laterals, but it is preferred, once again, for optimization purposes, that you always do a left lateral because that will minimize the heart magnification. Think about where the heart sits in the body. The heart's on the left side. If we do a right lateral, the heart's going to look much bigger, which could actually obscure part of that T-spine. Thus, we're typically going to do that left lateral whenever possible. It will reduce it overall and gives a better overall image. And we don't want that heart superimposing the spine. Superimposing the spine.
You sound like your cartoon.
It's not a cartoon.
No, the cartoon you made. That's
Oh.
what I'm sounding like right now.
Oh.
I do.
What's the name of the pathology where their organs are flip-flopped?
It depends on the organ's flip-flop, like heart would be dextrocardia. Dextrocardia, yes.
I don't understand how the heart superimposes the spine when they're like.
So basically, if I'm doing a right, I'm applying a lot more OID to the heart, so it's going to blow up on the image. Basically, the sides of it are going to start hitting the spine. It just gets so big. Whereas if I do a left lateral, it's going to be more of its natural size, and it'll just be more anterior and not get into the spine.
Oh.
It's just because it magnifies so much. Yeah. Well, where's your heart located? It's on the left side.
So if we do it like this, it's gonna.
Yes, left lateral like this is going to come out smaller. Yes.
Yesterday we were doing C-spine, T-spine, and Miss Anna was like, "Oh, don't send it yet because there's a doctor that wants to see how we're doing this." And so he came down and looked at it, and he was like, "How come all y'all's spine is facing this way and not this way?" Because he looks at CTs and MRIs, and he said it's facing the other way, so I always have to flip it. And so he's like, I mean, I know I don't want to mess up y'all's protocol or whatever, but is there any way y'all can like flip it before sending it? I'm like, oh my God.
Yeah, because it's so hard to push one button to flip it.
But I think
Yeah.
Mr. Abraham was gonna do something in the system or something that automatically does it. He was like, I always have to flip
That's
it.
just
The CTs, you read CTs.
Because,
Another
wow,
way.
it's so hard to go
I
on
know,
packs and
right?
hit the flip button.
I know.
That's just too much for their brilliant minds to handle, I guess. Good Lord. I've heard a lot of things like that before in my times in tech. I get these radiologists, they're so over the top, extra about stuff. Like, can you move the universe just for me? No. And we had like, where I worked, we had like it was a team of about 20 radiologists that rotated. There was a bunch of radiologists depending on the shift, and each one, I swear, had their own way they liked things. Some of them were so bad, they had an entire book printed out of how each doctor wanted their fluoros set up. And you had to go, oh, well, it's Dr. Kahn today, it's Dr. Braverman today, Dr. Phillips today. You had to set up according to their specifications. I was like, good Lord, that's just stop. All right. Heart position, long axis of the vertical column aligned horizontally. Please provide support for the head and lower portion if you can, like you see in the picture here. We do want to put their head on a pillow, and if you have sponges, go ahead and put it underneath their side. Why? It's going to align the spine in a straight line like this. Now, if we don't have these sponges, gravity's going to naturally pull the spine down slightly. It's very subtle, but once again, maximizing quality, optimizing. If we can raise that part of the body slightly and make it straight, just give it an overall prettier image. IR, same concept, guys. We're using T7, but you can put the IR of the light 1.5 to 2 inches above the shoulders. And here's the big one, guys. We do this like a chest with this one exception. Make sure that you center the posterior half of the thorax to the midline of the grid at T7. So when you find T7, you're going to move them slightly back, slightly forward to make sure you're centered right on the spine. Think where the spine is located, you want to make sure your central ray is penetrating the spine, not the ribs. Why? Because if I hit the ribs, that's not the star of my show, it's going to make that spine look more blurry overall. Whereas if I put the spine right in that central ray, boom, it's going to look beautiful, just like I want it to look. So it's really vital that you center slightly posterior directly on that T-spine. It's also going to allow you to collimate sharper as well if you're centered on the spine. Whereas if you're on the rib cage, you start collimating, you're going to risk cutting off the spinous processes behind the vertebral discs. Now, here's the big one too, guys. This is what I was talking about earlier. We'll get some of those spoilers flying around. Once again, it's all about image optimization. Because we are penetrating a very thick area of the thorax, we're using high techniques, scatter is going to increase. The more scatter we have, what happens to our image? What's those technical terms? It becomes more noisy, and what goes down?
Quality.
What's another word for quality? Starts with an S.
Oh, the
Two
S
words.
level.
S
value.
and R.
Spatial
Spatial
resolution.
resolution.
Good job.
Spatial resolution is going to go down. The more noisy the image becomes, the less spatial resolution you have, the less HD and pretty that image looks. So, how do we mitigate that? Mitigation factor is adding a lead strip or a shield behind the back. Because that scatter is so extreme, that shield is going to absorb that scatter, and we're going to get a beautiful image when we utilize that. Now, how many techs have you seen do this? Probably none. I always did this because this gives you the prettiest spine images when you put that behind the patient, guys. It's really worth utilizing if they'll let you do that. So you simply use a shield. Now, if they're standing, obviously you can't do this, but if they're on the table, you'll be able to utilize that lead shield. And that's to reduce scatter and give us a better overall image. Now, if they're lying down, also flex the hips and knees for comfort, and make sure you superimpose the hips and knees on top of each other to ensure we have a true lateral position, because what gets people the most on this, if you're doing it on a table, is patients will shift their weight on you, and they'll start to tilt backwards, tilt forwards, because you have back pain, it's gonna be hard to sit, it's gonna be hard to lay on your side. So don't let them tilt, make sure you do a walk around. I always say do a walk around before you make your exposure, make sure that back is nice and straight, true lateral, before you take that x-ray, especially because y'all are laying them down on the table for lab. Do a walk around, look at them from the top of the head, behind, don't just look behind because you might miss something. Ensure they're not rotated on you. They're nicely in a true lateral. And for me, that's a good place to put your marker as well, right behind the back. That's what I always did. Don't try to put it in the front because you're going to end up probably missing it or getting it in the middle of some anatomy you don't want to be in. You always want to avoid having your marker in anatomy if you can avoid it. Sure.
How do you feel about stitches, like based on surgeries? Do you think you should get that surgically fixed? Or
Yes. Yes, you should.
What was your question?
A slip disc, you should get that. You should go see a professional. I have a love-hate relationship with chiropractors. I know some are very talented, but I feel like it's just such a risky move, having moving your discs around and popping stuff back into place. I'm like, I'm gonna go see a back doctor personally. a real back doctor, I would get it surgically fixed personally. That's a spinal cord you're talking about. They pop one thing the wrong way, they don't sever it or damage it. That's just me. Yes.
I forgot, I don't know if you said this already, sorry, I'm kind of out, but for the marker for the AP, he's fine.
Or you go either, you can use left or right and just put it up by the neck. That's
Oh,
what I
by the
do.
neck, okay.
All right, guys, central ray, perpendicular central ray. Yes.
Could you go back for just a split second?
Sure.
Thank you.
No, that's a lot to write on that slide.
That's it.
Good? All right, perpendicular central ray, guys. But if the spine's not horizontal, in other words, they have like a very curvy spine, let's say they have a lot of kyphosis, like there's a noticeable curve, like a hunchback, then you can do an angle of 10 to 15 degrees cephalic, and that will give you a better looking image overall. It'll help you get the whole spine on there too without missing anything. That's only if their spine isn't horizontal or straight, but most commonly you just think of that perpendicular central ray. That will enter at the level of T7, slightly posterior like we talked about. Collimation is made the same as the AP. You want at least 7 by 17. Don't leave it open. Don't leave it open.
Yeah, he's
And you have an option of a 40 to 48 inch SID. If you feel like there's a lot of magnification going on, you have the option of 48, but ideally you just stick with the 40, guys. That's the easiest thing to remember. I don't feel like it makes a big enough difference to go to 48 personally. It's a very subtle change.
So only for the angle if they have
Feel like a lot of curvature in their back.
We do it 48 because of all the mass that's going through.
Because of what?
All the mass down here.
No, it's just because of parts being magnified. It's just supposed to help reduce magnification more. Like, let's say, for example, you're just really having trouble getting that whole spine on the radiograph because it feels like maybe the spine's magnified. You can do 48 and you'll fit it on there a little bit better. So you have very long spinal columns. Not everyone's vertebral discs are designed the same way. So you have very large ones.
Then why do we do C7, lateral C7 and 72?
Because there's a lot more OID in comparison. So think about the C-spine, you've got a whole neck here causing a bunch of space. Now my T-spine's against the wall, there's still slight OID, and if I feel like that spine's just not fitting, I can go back further, because one way you always can mitigate magnification is increasing that SID if they're not fitting. So it's just a option for critical thinking, so to speak. If you want to maximize your image and may fit it a little easier. You're just having a lot of trouble getting that whole T-spine on there. All right, respiration, guys. Please write all three of these because all three are options for a lateral T-spine. We can just simply expose with them breathing normally, like orthostatic breathing. We can do an actual breathing technique, and that kind of maps it out for you, but just know that you can do a breathing technique. That's if you're interested in how it works. And then we can just simply suspend at the end of expiration if we choose to as well. So breathe normal, breathing technique, or suspend at the end of expiration. All three are options for lateral T-spine. Whereas the AP, we only just do that third option, suspend at the end of expiration.
How do we know when to use?
It's just personal choice. Now the best one, obviously, is bullet point 2, if you can figure that out. But most of your texts are just going to do bullet point 3 because it's the easiest, if I'm being honest. I just want y'all to make sure you know that's expiration, guys, on both of those. Even though we're in the chest area, we're not holding the breath, we're blowing the air out. It's expiration.
I'm not even gonna ask about the text.
Oh, that's a good question. I have all three. That's right. Yes, Cody?
So most of the time when you shoot an X-ray, like you'll shoot it and then you'll hear like the beep, and then like when that's done, you know the X-ray is like taken. So like, would that mean for like the breathing technique one, would you just hold it after that
That's a good
and
question.
then stop, or like?
So that's a great question. So for breathing techniques, you see how it says 2 to 3 seconds here?
Yeah.
When you set a manual breathing technique, you're gonna hold that exposure. It's gonna be a long beat. It's gonna go beep for about 3 seconds. And it's actually making the exposure that entire time you're breathing while you make that actual exposure. And then it will give you a beautiful image if you did it right.
Okay.
It's very hard to calculate, 'cause you gotta set the mass, the time,
So
basically
you have to do it
size.
all like manually?
It's all
first,
manual.
and then- Okay.
It's all manual, yeah. All right, so what are we looking at? Of course, once again, the thoracic bodies, 1 through 12. We're gonna look at those disc spaces again, and do remember that on the lateral T-spine, we are seeing those intervertebral foramina. That's different from the C-spine lateral. T-spine lateral, we're just gonna see the intervertebral foramina and the lower spinous processes. Now, one thing to keep in mind is that T1 through T3 are typically not gonna be well seen. So almost every time when you do a lateral T-spine, unless you have a very small patient and you can see all 12 easily, we're gonna do another additional X-ray to see that C7, T1 interspace. Y'all remember what that was? Swimmers. So same concept with the C-spine guys. If we're taking a lateral T-spine and we cannot see C7 and T1, we're gonna do a swimmer's view to make sure we can see those. And this is kind of showing that same concept, guys, once again, when it comes to counting these. Here's L1, it's cut off. The first full vertebrae we see is right here. That will be 12, and then we'll count up backwards from there. So once again, that kind of shows you too, guys, why it's so important that you center posteriorly a little bit. If I'm centered like a normal chest, I'm gonna be way over here in the rib cage and the lungs. I'm just gonna lose all the detail of that spine. I wanna make sure I'm right on top of that spine because that's what we're interested in. That's the main thing we're imaging. Joe wrote that down, right? We do a swimmers when we can't see C7, T1. That applies to C-spine and lateral T-spine. All right, of course, no rotation. We do want those posterior ribs superimposed, and we want those open intervertebral disc spaces. That's also why it's really good to build up the body and lateral if they're on the table, because if you build it up and get that spine straight, it's going to open those disc spaces even better. If it's not built up, they're going to be a little more slightly closed off in comparison. Almost to the end, guys, and we'll take a break.
Execute order 66. Like, that's what I was checking with.
Because you saw the 6 and 6.
Yeah, that's just the first thing I can.
All right, last position, guys. This is going to be our oblique T-spine X-rays. Now, not a lot of detail on this one because this is becoming a more increasingly obsolete view, but we're going to focus on just what you need to know if it was to show up on your registry. First of all, we have the option of doing anterior versus posterior obliques. So we can do LPO, RPO, LEO, REO. It's up to the tech's choice. This is going to be the only oblique in X-ray positioning where we do 70 degrees, guys. Very sharp oblique, almost lateral essentially. 70-degree oblique. We're still going to be centered to the level of T7. We'll keep these details very minimum, just to what you need to know. Because I've never done one of these my entire life, actually. I've never even seen one ordered. They're still asking about it. 70-degree oblique, centered at T7. We have the option of doing anterior or posterior obliques.
Because I remember you saying earlier it was like opposite, so for the C-spine obliques you see the
Posterior obliques is the side up.
well,
If you do 70 degree obliques
I
and
remember you saying like you said
It's 45 degrees.
Oh, yep, I'm getting to that.
So
Yes.
it's different?
Yes.
Oh,
It's just showing what it looks
That
like.
was C-spine.
Picture there, guys. So, to answer your question, here we go, guys. When we do oblique T-spines, we are focused on the zygapophyseal joints being opened. Remember, that's inverse of C-spine. C-spine, we see zygapophyseals in the lateral. T-spine, we see zygapophyseals on the obliques. Let me go back. For C-spine, we see the intervertebral foramina in the oblique. For T-spine, we see the intervertebral foramina on the laterals. So they're inverse of each other, how we look at those parts. So what you guys see, guys, all 12 vertebrae, of course, and then the open zygapophyseal joints. And it's just a horrendous picture. It just looks like trash to me. Very ugly picture. Probably why we don't do them anymore.
What are you doing with it?
I don't know, I just never order one like that. I've never seen that order before. I don't even know a single tech that's ever done this x-ray. So know that it's a 70-degree oblique, guys, and we do it specifically to open up the zygapophyseals in the T-spine area. That's the two most important parts of info there. Oblique T-spine x-rays.
So is there any other T-spine X-ray that opens up those?
No, it's just
So
not.
Just this one.
I guess it's just never an area of concern.
Yeah.
I've never seen them order these. It may be also impact of the increase in CT exams for spinal injuries, because you'll probably see this yourself. Someone comes with a spinal injury, oh, just send them a CT. Send them a CT. Send them a CT. And that shows you everything, honestly. Yes?
Mr. Donahue, what does it mean by optimal exposure factors?
What do you think that means? You should know what that means.
The contrasts that the light,
What are exposure factors?
KVP and mass.
KVP and mass, there you go.
So what do you, that means that they
It
should be
means
correctly
setting
selected.
it properly.
Oh, I
Setting
see.
it properly.
Make sure back
When you see exposure factors from KVP, mass, SID, all that stuff you do with your tube and control panel.
Thanks.
All right, guys, let's do some review questions. There's not 17, by the way. That's broken up between L spine, T, and C, so it's going to jump around a little bit on those numbers. Let's see how you do, and then we will take a break and do a Kahoot review. So, identify the projection and the anatomy of interest.
D is in D.
D as in Doge. As in Doge.
D is in
Doge cat.
Don't do
Don't talk
that.
about Doge.
Yes, D, lateral, cervicothoracic, also called what, guys? Swimmer's view. Swimmer's view or swimmer's method. All right, what is that?
Ooh.
So
You know it's an oblique, right? You at least know that? I didn't go over this in class, but there is a way to know
That's
if
a
we're looking at
PA.
PA versus AP.
It's
I'll
a
tell you in
PA.
a second. You said PA, it is a PA. Now the way on the C-spine that you can tell, because when we think about the AP versus PA, they look pretty synonymous. They almost look exactly the same.
Mhm.
When we do a PA axial oblique C-spine, we're gonna put the marker behind the head. See what I'm talking about? Behind the head. When we do an AP axial, the marker goes towards the jaw in the front. So let me say it again. For PA axial, we mark posterior. For AP axial C-spine, we mark anterior. Keep that in mind. Come up with another question.
You can tell by the head too.
You can tell by the head.
Yeah. That's a, right?
How do you tell the
It's pretty synonymous with a. How do you tell the difference between a lateral? So, good question.
There's no.
Because of how open these foramina are. If you see big open circles here, guys, it's oblique.
Mhm.
But if they're not open, it's
It's
lateral. Yeah.
You're just mostly
I
the
think I have a
parts.
lateral C-spine on here. You'll see what I mean. So PA axial oblique, we're looking at the left intervertebral foramina
And you said the marker goes behind the head.
for your
PA.
PA axial
Okay.
obliques. So if we're looking at so another question here, guys. If this is a PA axial oblique and we're looking at the left intervertebral foramina, which oblique is it? LEO, very good. LEO, excellent. What is that?
B is in boy.
AP axial C-spine, very good, very good.
That's
C
it.
is in boy.
That's it.
Is it oblique?
Oh, I'm sorry,
So
it's
B.
B.
Yeah.
That's my fault. I was doing those really fast this morning. That's AP axial. Don't take a picture of that. That's AP axial C-spine. What is that, guys?
That is the dad.
B.
open mass.
No, A.
Oh, it's
It's
not
a
the
A.
dens. Be
A
careful.
A is in apple.
I'm glad you said that, Jay. It's an easy mistake to make.
Oh, the open mouth. I'm tripping. My fault.
So be careful. Y'all see how tricky that is? We can see the dens, but it's not the fuchs, because the fuchs is identified by
Close
the
enough.
dens through what?
Foramen.
Foramen magnum. This is an open mouth atlas axis.
It's a very good.
Very nice one too.
Mm-hmm.
What is that?
Yeah.
What are we
Lateral
identifying?
Z joint. No.
There's two lateral T-spine answers up there, but which one are we?
D.
Oh, the lateral. The lateral.
D.
Interforamen. So C.
It's not D.
C is
C?
in cat.
It's C. So remember, guys, for T-spine, we see foramina and a lateral, zygapophyseals on obliques. When we go to C-spine, for C-spine, we see zygapophyseals on the lateral, foramina on the obliques, where they're inverse of each other. All right, there's your lateral C. So you see how those little foramina are closed off now? And we're looking at zygapophyseals now. I'll just give you the answer. What is this? Lateral C, you'll look at zygapophyseal joints. And what is that? That's the baby bird mouth?
Big bird.
That's the fuchs, AP big bird, AP dens, fuchs, spine. What's the alternative to this? PA Judd. PA Judd. Very good.
Mm-hmm.
And what is that? APT spine, kind of obvious. You see anything with L spine, guys? Just keep in mind, we haven't even talked about L spine yet. You can eliminate those answers very quickly. I love L spine though. Can't wait to get to L spine. What is that? Based on what we just talked about.
That's the AP.
Well, where's the marker opens for
AP axial.
It's a RPO
oblique.
to
That's
look
AP
at the
axial
middle.
oblique. You are correct. It's LP, AP axial oblique. To look at the left intervertebral foramina. Thus, which oblique specifically is that, guys? Based on the concept of foramina and the C-spine obliques.
RPO.
RPO. So in RPO, we see the left. LPO, we see the right.
So this is the only spine column that does the opposite?
Yeah.
Because I was
C-spine's
looking at
weird
the
like
L
that.
spine and it's the same.
It's more one-to-one
side.
on those, yeah. Yeah, the C-spine's funky like that.
Like
Yeah.
how does, I mean, why? Like how does that?
That's what Reagan was asking. It gets really complex. It's the way the anatomy is thrown to the side in the oblique. And
Think about it too much.
y'all aren't thinking about it too hard. You're not going to be asked that. Just know that's how it's represented. It's
I tried for
complicated.
y'all.
I did.
It's very complicated in the way it throws it to the side based on that oblique. It's the way the beam diverges, so to speak. It's weird. It's weird.
But understanding it does even eliminate answers.
And that's, well, not technically the end of chapter 9. That's
Section 9.
end of part 1 of chapter 9. Yes. All right, guys, take a break. I know your brain's looking kind of fried out there. Take a quick break, guys. About